Everyone, I think we're going to get started. Hello, my name's Ann Greiner. I'm the president and CEO of the Patient-Centered Primary Care Collaborative, and we're so pleased about this turnout today because we know that there's a couple of things going on in Capitol Hill this week. So welcome back for those of you who have been on recess, and we're really pleased to see everyone. This is our 6th annual evidence report that focuses on the patient-centered medical home, and this year on other advanced models of primary care. And we're so glad to be able to be bringing these research results to you. The Patient-Centered Primary Care Collaborative, or for short, the PCPCC, is a nonpartisan membership organization that is focused on making primary care more robust and more patient-centered through policy and advocacy efforts. And I am so pleased to be at the helm. This is my 15th week on the job, so it's I'm brand new, cut me some slack. And I will trumpet the organization's work over the last decade for a moment. We are really credited with working with various stakeholders across the healthcare system to put the patient-centered medical home on the map, and I think it really has helped to elevate primary care, and yet our work is not done. Today you will hear how the patient-centered medical home and other advanced models of primary care are working with respect to delivering value from the patient perspective, from the payer perspective, and also from the delivery perspective and the perspective of providers who deliver that care. And we'll be looking at it through the lens of cost, quality, and utilization. Deriving more value from the healthcare spend via payment and delivery reform is a purple policy, a policy that both Republicans and Democrats have long embraced. And this is particularly true when you turn your lens to delivery and payment reform focused on primary care. Primary care is foundational to our payment system, or to our healthcare system, and when it is at the center, it is truly transformative. So if you or your bosses are looking for an effective, big tent, nonpartisan policy issue to focus on, you've got it right here, elevating primary care. And before I turn the podium over to our next speaker, I'd briefly like to thank all of those who worked so hard to make today's report and event possible. First, we'd like to thank the House Primary Care Caucus, particularly the caucus co-chairs, Congressman Courtney, and I think Maria's here to represent Congressman Courtney, and Congressman Rozier from North Carolina, Republican Congressman Rozier. They were instrumental in securing this room and also in the fabulous turnout that we have here today. I also want to give special thanks to the Robert Graham Center, particularly Dr. Jabapour and Dr. Bazemore for all their work to research and write the evidence report. And thank you to the Milbank Memorial Fund and to Chris Kohler, who's the president and CEO, who you'll be hearing from later, for their sustained financial and intellectual support for their work, for this work over the many years. And finally, thank you to the Blue Cross Blue Shield Association, who sponsored this event so that all of you would be the first to know about these important findings and their relationship to policy. With respect to today's agenda, after brief remarks from Justine Handelman, Blue Cross Blue Shield Association, Dr. Jabapour will present the main findings from the report, and she will entertain questions after her presentation. Chris Kohler from Milbank will then follow and reflect on the policy implications from the report. His remarks will be followed by a panel from Blue Cross Blue Shield of Michigan. And Michigan is a really wonderful exemplar case of the patient-centered medical home. They have been working and evolving this model for the last 8 years, and they have some stellar results, which you'll hear about. But you'll also hear from a physician's perspective, from a payer's perspective, the health plan, and also from a patient perspective, what it's like to be in a patient-centered medical home. It might be a little bit abstract to all of you, so they'll try to give you a feel for what it's like to be in such a delivery model. So without further ado, let me introduce Justine. She's Senior Vice President of Blue Cross Blue Shield Association. She leads lobbying and policy development for the association. She works with the administration, Congress, government organizations, and other associations, government agencies. Thank you so much.
Well, it's great to be with you all here today. Sorry to be running a few minutes behind. I had 2:15 on my calendar, so apologize, but so glad to make it here in time because this is such an important event and important work that's going on. And I too also want to thank Representatives Courtney and Rouser for their leadership on this very important issue. And to also thank the Patient-Centered Primary Care Collaborative, Milbank, and the American Academy of Family Physicians Graham Center for putting together this very timely and informative session, and also the important report that has come out today. I think as you review the report, you'll see many programs with Blue Cross Blue Shield support, whether it's through direct funding or through practice improvement and tools to help physicians. And we are really working collaboratively with the providers on this important work. In fact, the Blue Cross Blue Shield system has the largest network of patient-focused care. We spend more than $121 billion a year, and this represents 30% of all medical claims. We're in virtually every state. We have more than over 400,000 providers, over 1,200 hospitals, and more than 53 million members. So it's really tremendous what's going on. Collectively, we're reimbursing more physicians and hospitals for quality care and outcomes than any other plan in the US, and we're really proud of that work. And we have many great results, and you'll be hearing that today from Michigan. As you review the report, you will see many programs that are just benefiting consumers in the community through this collaborative. I also want to applaud CMS for their leadership in moving Medicare towards value-based payment. It's very important as CMS moves forward to learn from and, where possible, align with what's happening in the private sector. We are seeing tremendous results, as you'll hear more about today. And it's important to point out that sustained success depends on government programs allowing for innovation at the local level. Care is delivered differently wherever you are, and really understanding what's happening at the local level and adapting the programs to meet the needs of the local level is critically important. So as MACRA implementation begins in earnest, primary care practices are considering the payment pathway that's best for them and what's best going to meet the patient needs. And in general, as we work with providers in the community and as we look towards MACRA implementation, we do believe that it's very important that alternative payment models should have a great deal of flexibility. Again, as I talked about, meeting providers where they are in the community. And clinicians in advanced payment models should also, if they're in Medicare Advantage, they should get credit for Medicare Advantage, not just the traditional Medicare program. We also believe that CMS should ensure that the patient-centered medical home is maintained as a foundational component to a transformed healthcare system. Private sector patient-centered medical homes shouldn't be held to a more rigid standard than a patient-centered medical home in a CMMI demonstration. And we also believe it's important that effective incentives, they do require putting providers at some risk. But again, as I mentioned, healthcare is delivered locally, and plans are acutely aware and attuned to where the providers are in their community and what their needs are. So working directly with those providers to determine what is the best path, whether it's a glide path to expanded risk arrangements or other tools and supports that's needed, is critically important to look at that. And finally, I just want to point out that while changing provider incentives is necessary, it's not sufficient. Blue plans are committed to partnering, as I've said, and you'll continue to see this as you review the report, with the providers in their community to provide them with the tools they need, not only financial support, but also practice transformation support. And I just want to end by saying that continuing to invest in primary care is so critically important, especially now as we look at how we can provide high quality care at more affordable prices. And the Blue Cross Blue Shield system is committed to continuing to work side by side with the providers in our community to help deliver the safest, highest quality care. So again, thank you for the opportunity to be here today. It's really great to have the report and to have the experts who are going to talk about what's really happening to transform care delivery and the important emphasis of primary care. So thank you for having me here today.
Thank you, Jessica. Let me introduce Dr. Jabapour from seated, because it's a little bit tight up here. Dr. Jabapour is a family physician, and she practices here in Washington, D.C. She attended Georgetown University, where she received her medical degree and completed her residency at Providence Hospital. She's an assistant professor in the Department of Family Medicine at Georgetown University School of Medicine, and she is affiliated with the Graham Center here in D.C.
Hello, everyone. All right, looking good. Okay, can you hear me? So I'm Dr. Jabapour. I'm a professor at the Department of Family Medicine at Georgetown University and a close research collaborator with the Graham Center. And I'm here to give you a brief overview of our report on the impact of primary care practice transformation on cost, utilization, and quality. The Robert Graham Center is the research division of the American Academy of Family Physicians, and although we are closely related to the Academy, we do have editorial independence. We're made up of a team of 3 full-time physician researchers, as well as economists, geographers, social scientists, and we are helped every year with our research by 2 health policy fellows. I was one of those a couple years ago, as well as monthly scholars who rotate with us from medical schools, residencies, physician organizations, and hospitals throughout the country and the world. So the Robert Graham Center, as well as others, came together to build this report that's being released today. And as you can see, we were a pretty diverse team made up of physicians, PhD researchers, and other stakeholders in the patient-centered medical home. And before I get into the report, just in case those of you might not know what is the patient-centered medical home, I wanted to give just a very brief overview. The patient-centered medical home is a theoretical model of primary care delivery. In 2007, a few primary care associations came together and developed the joint principles of the patient-centered medical home. Since then, the patient-centered medical home and its definition has continued to evolve, but there are a few attributes that are always part of the medical home. One is that it's patient-centered. So the patient and their family members are part of the decision-making process in their medical care, along with the physician who's there to help educate and guide them. It's comprehensive. So when a patient comes to my patient-centered medical home, I'm not only taking care of their acute issue, like their sinusitis or their broken ankle, but I'm also taking care of their chronic issues, like their depression, their anxiety, their hypertension, their diabetes. And I'm also giving them preventive screening. I'm doing their pap smears, giving them their immunizations, sending them to get their mammograms and their colonoscopies. It's coordinated. So whether they're in my office, the specialist's office, whether they've been hospitalized, they're in a nursing home, or receiving home health care, we're all communicating together. It's accessible. In fact, many patient-centered medical homes have night and weekend hours. Some have physician and nurse hotlines that are available to you 24/7. Many have used IT resources to create a patient portal so that you have access to your medical record at any time from any computer. And of course, it's committed to quality and safety. And those are the key attributes of the patient-centered medical home. So now let's delve into the report, which has taken up the last 6 months of my life. So our task was to review the literature published about the patient-centered medical home and advanced primary care in 2016, specifically looking at the outcomes of cost, utilization, and quality. And there are a few differences this year from the past years. Number one, it's a new set of authors, which I introduced in the beginning. Also, we had a broader scope of research. So we didn't only look for articles that talked about the patient-centered medical home, but we looked at articles of places that may not have said they were a patient-centered medical home, but had attributes of advanced primary care, those 5 core attributes that I talked about previously. We also had included, instead of just focusing on cost, we focused on utilization and quality outcomes too, which we thought was important this year. And we had a very rigorous search criteria. We actually enlisted the help of 2 library scientists, one at Georgetown University and one with the American Academy of Family Physicians, who helped make sure that our search terms were broad enough to make sure we did a comprehensive search of the literature. And after doing this, we had 45 peer-reviewed articles and a few gray literature reports. And gray literature was essentially those reports that had rigorous method sections but just weren't published in peer-reviewed journals. I show you this slide not because I want to go through it in detail. You can read about it in the methods section in the report. But essentially, we used 5 databases with the help of library scientists. We initially came up with 1,800 articles, and through a very rigorous process of using inclusion and exclusion criteria and independent reviewers, we came up with 45 peer-reviewed articles. And we noticed that our articles kind of fit into 3 different categories, which you'll see referenced in the report. The first was this PCMH implementation study, and that's what you usually think of when you think of looking at the PCMH. So these were studies that looked at before PCMH was implemented and then after, and what was its impact on cost, quality, and utilization. And then we had this set of studies that didn't say they were a PCMH anywhere in the report, but they had the core attributes of a PCMH. And we called those the features of PCMH care delivery. And then we had another set of studies where they had already established PCMHs, and they made little tweaks to their PCMH to see if that improved outcomes or not. And most of the tweaks they made had to do with adding team members to their PCMHs, such as a social worker, a care manager, sometimes a pharmacist. So what did we find? If there's anything that's a take-home slide from the report, it's this. So in green are the articles that reported positive results. In yellow are the articles that reported mixed or neutral results. And in red are the number of articles that reported negative results. A word about mixed results. We included something in the mixed results category if, for example, the article talked about 2 different patient populations and one patient population did well statistically significantly and the other had neutral results, that was mixed. Or if the article showed a positive trend or a negative trend, but those trends did not report statistical significance, we called them neutral or mixed. And as you can see, in terms of cost, actually an overwhelming amount of the articles were positive in terms of the impact of the patient-centered medical home on cost. Quality, there was a mix of positive results and mixed results, and I'll delve into this a little bit more. And in terms of utilization, we looked at inpatient utilization, ED utilization, and PCP utilization, and generally positive or mixed in terms of utilization. So let's delve into each of these. When we looked at costs, there were overall positive costs on the impact of PCMH on cost. When we're talking about cost, we're talking about cost to the healthcare system that was studied. And what we did find was that there were increased savings over time, so the longer a PCMH had been around, and also increased savings if you had patients with more chronic conditions. The only negative article we really found on cost was one study, and it was a very limited patient population. It dealt with patients with breast cancer, which tend to be more expensive to the system anyways. And then when we looked at quality, we found generally mixed results. And there are a couple of explanations for this. One, it was rare that a study only looked at one quality measure. In fact, usually these studies looked at anywhere between 5 and 15 quality measures. So you can imagine that if you're looking at 15 quality measures, it's going to be really hard to have statistically significant positive findings for all 15 measures. So if 10 of them were positive, 2 of them were neutral, and 3 of them were negative, it was still a mixed result. Also, when we're looking at quality measures, we're generally looking at a very specific patient population. So we're looking at the diabetics, or we're looking at people with heart disease and whether we're getting lipid screening. And when you're looking at such a small patient population, you might not have the power needed to make a statistically significant result. And third, it's unclear if we were actually studying the right measures. So perhaps the quality of care the patients were getting and the quality of their health was improving, but we just weren't studying it right. So when we looked at the studies on the patient experience, interestingly, all three studies that looked at the patient experience reported positive findings. So even if the LDL wasn't being measured or the A1C wasn't being measured for diabetics, the patients themselves felt that their quality of care was improving. And then when we look at utilization, we looked at three different categories. One would be primary care physician utilization, and we would expect that in a system that is running well, that would actually increase as long as it led to a decrease in the number of times patients were going to the emergency room or being hospitalized. And in general, we did find that primary care physician visits increased, ED visits decreased, but there was really no impact on inpatient hospitalizations for the most part. So that was the peer-reviewed literature. Moving to the gray literature, we took a look at two big reports of CMS initiatives. One was the Comprehensive Primary Care Initiative Year 3 report. The Comprehensive Primary Care Initiative was a 4-year multi-payer initiative started in 2012. It included 7 US regions and essentially offered population-based care management fees and shared savings to support those core primary care functions I talked about in the beginning. And then the multi-payer Advanced Primary Care Practice Initiative, this was the Year 3 report. It didn't really fit our study in that it was only a thematic analysis in Year 3. They didn't have numbers published yet for cost, quality, and utilization, but we found some pretty important themes, so we did include it. The Multi-Payer Advanced Primary Care Practice Initiative is a 3-year multi-payer initiative, started in 2011. It began with 8 states, and in 2014, 5 of the 8 states were asked to continue through 2016. And once again, multiple payers came together to offer a monthly care management fee for beneficiaries in these advanced primary care practices. So here's what we found with CPCI. If you look, only the categories with 3 asterisks near them were statistically significant results. So in terms of cost, in Year 1, there was a statistically significant decrease of cost by about 2%, but this was dampened by Year 3. In Year 3, there were no net savings. In terms of utilization, there were decreases in ED and hospital utilization, which is going in the right direction, but only statistically significantly so in Year 3. And in terms of quality, they looked at about 50 different quality measures. The only quality measure that had any sort of statistical significance was urine protein testing in diabetes. That was statistically significant in Year 2. It increased by 1.6%, which is good that we're testing more diabetics. But in Year 3, it actually went in the opposite direction, though not statistically significantly so. Now, these results may not be as brilliant as we might want, but if you talk to the medical directors and practice managers of CPCI programs, they really felt that the payers coming together was improving the quality of care that they were giving to their patients. And I think CMS agrees because we're taking CPCI and the 7 regions and expanding it into CPC Plus, which includes 14 regions. So we're taking the lessons learned and the bright spots and trying to expand that even further. And if you look at states that were in the CPCI program individually, you actually see better results than the nationwide results. 2 states that we focus on in the report in detail are Colorado and Oregon. Now, we should note that CPCI is not the only program in Colorado and Oregon, but nonetheless, Colorado and Oregon showed great changes, positive changes in the cost to their system and also utilization. Neither one of them measured quality. And if we look at the MAPCP results, once again, this was thematic in nature, but when they interviewed the medical directors and practice managers and physicians, they felt that care management had the most significant impact on utilization and expenditures, especially if you reached out to recently hospitalized patients and you risk stratified patients and allocated resources to those that were most in need. Now, in June of 2017, MAPCP did release some of their state-specific numbers, and some states actually did really well, including Michigan, which I think we'll talk about shortly. Another MAPCP state that we focus on in the report in detail is Minnesota. Minnesota also had great improvements in cost in terms of utilization. They had an increase in emergency department utilization, but all other utilization actually improved, and quality improved, especially for their asthmatic patients. So in conclusion, our analysis showed a positive overall result in terms of cost, quality, and utilization, but not always uniformly because there were mixed results. There were a few themes that we pulled after reading the articles that I just wanted to share with you. One was that patients with greater comorbidities, so our sicker patients and systems with these patients, actually made the greater earlier strides. Second, and I think this is important, is that practices need time to show positive improvements. We saw this over and over again in our articles. Those studies that lasted 5 or more years had much better impacts than those that were studied after a year or two. And also, when we look at Michigan, which we do in the report and we will hear later, Michigan is the longest running and largest PCMH, and they've had excellent results. So we just need to give these practices time to work. Also, we can't apply a one-size-fits-all approach. Every PCMH we read about was different. When you've seen one PCMH, you've really seen one PCMH. And so therefore, we need to give areas and regions and practices latitude to apply their PCMH as long as they're meeting those core attributes. And finally, there's this thought that our mixed results are probably due to a positive spillover effect of already transformed practices on practices that have yet to transform. It's hard to separate out the effect of the patient-centered medical home right now because it's so widespread. In fact, it's estimated that about 45% of family physicians work in a patient-centered medical home. And anecdotally, having taught at 2 different medical schools and 2 different residencies on both coasts, this is how we're teaching our primary care physicians to practice. So because of that, it's really important that we continue to support research in this area, and we also continue to support these practices as they transform. Thank you.
We're going to have time for questions later, but are there any burning questions for right now?
Excellent. I know it is a little bit warm. Okay. So next, I wanted to introduce Chris Kohler, who's president of the Milbank Memorial Fund, a national operating foundation that improves population health by connecting leaders and decision makers with the best evidence and experience.
You just took away the first half of my
Oh, I'm
presentation.
sorry. You should have told me. I should have talked to you about it.
No, it gives me more time. Thanks, Yalda. Have to raise this a bit. So I want to talk a little bit about the policy implications of this. I'm going to orient it towards the federal perspective, although as a recovering regulator from a state standpoint, you're going to hear some state perspectives come through as well. The fund is really committed to this work around primary care. We, as Ann said, we sponsored this report for a while. The evidence is really strong about how any high-performing healthcare system has to have primary care at its core. The evidence is also strong that we in the United States don't follow that evidence. In spite of all that work, about a nickel out of every dollar in healthcare goes to primary care in the U.S., less than half the amount in high-performing health systems in other countries, and even in this country. So think about that. 5% of our healthcare spend is going to this important resource, and that's less than what we see high-performing health systems here or other places spend. So how do we change that? Well, the first part is we got to know what constitutes high-quality primary care. We don't just want to, I've been there. Justine doesn't just want to shovel money into primary care because it's primary care. Sorry, Yalda. It's got to be good, or Dr. Stefanik. And the patient-centered medical home helps give us a framework for what constitutes high-quality primary care. I think what you got in Yalda's report is this really strong emphasis on evidence. We could stand here with a bunch of pom-poms and say primary care is important, but if we really want to get better at this, we've got to act on what the evidence tells us about what is working and what's not. That's why the fund has been very supportive of an evidence-based report rather than just a cheerleading session. And what I want to talk about is if I could sort of take away kind of 3 themes that come out of this report that was just given to you. The first would be this notion of persistence, that we got to stay at this for a while. The second is this notion of learning. Anyone who's looking for a silver bullet, they can take back to their boss and say, this is going to save money, this is going to balance Medicare next year. Not going to work. What we're doing is learning how to do this rather than, and getting better at it than having a silver bullet solution that comes, that we can all implement. And then the third is this notion of partnership. And I'm going to come back to that at the end as I introduce our next folks. So in terms of what you can do with this, particularly from a federal perspective, I want to offer 5 points. Now, the normal audience I'm told, can only handle 3 points. Speakers say only never get past 3, but because this is a DC crowd, I'm sure we can handle 5. So the first, and Justine mentioned this, is the work of the Centers for Medicaid and Medicare Innovation, CMMI, and the payment reforms. As someone who worked in state government, before that ran a Medicaid managed care plan, the dirty little secret is that we all follow Medicare's lead. Medicare really sets the tone, and the work that CMMI has been doing around payment reform is absolutely heroic. Are they hitting the bullseye every time? No. Are they making the delivery system better, learn faster, using the power of their money? Yes. So the work of CMMI has to continue if we want to have an improving healthcare system. It's Medicare's responsibility as the largest payer to learn from their mistakes and their successes and make improvements going forward, because the commercial payers follow them, as do the states in Medicaid. The second is around MACRA. MACRA is sort of the backstop for the innovations. I think it's significant that it actually was bipartisan health reform that was passed. There is no doubt that MACRA is going to get some stuff wrong, but the fact that it's moving off of fee-for-service and learning as they go, these results can directly inform what happens with MACRA. The third is that high-quality primary care should be a benefit for any publicly funded program, whether it's public employees, Medicaid, Medicare, or subsidized commercial health insurance. We want high-quality primary care. It makes sense. It's cheap, it works. We're learning what constitutes high-quality primary care. You want to see it be a part of any program that the public sector is paying for. The fourth area is around teaching. Dr. Jawapour talked about her experience in teaching. The largest funder of teaching physicians is Medicare. Graduate medical education is very hard to reform. We've done some really interesting things with teaching health centers, and Medicare can support that going forward. So I would encourage using the lessons around high-quality primary care to train more of those docs, more primary care in more community-based settings. You want to train them to do this kind of work. You don't want to train a bunch of specialists in hospitals. And then the fifth and final, and Andrew and Yalda didn't pay me to say this, is to keep funding health services research. Small little piece, but we're only going to get better if we improve what we measure. Health services research is about improving, and we should continue to fund ARC and other efforts at health services research so we can learn what makes a difference. It's our responsibility because it's the public's money that we're spending. So those are some from a federal standpoint. The bad news is that while Medicare is the big dog here, they can't change it by themselves. Dr. Stefanik is seeing patients from Medicaid, Medicare, commercial, uninsured. He is not going to treat them differently based on what insurance carrier they have targeted over their head. His plea to you from a policy standpoint is to stop the madness, is to align payments across providers, align incentives, so we're asking the same sort of thing. He'll work with that so long as the signals from the payers are consistent. And they're going to look different in Michigan from how they look in Oregon or how they look in Texas or in the People's Republic of Vermont. And so you want to make sure that you get that flexibility that Justine is talking about. And I think that's one of the most important things to come out of CMMI is that they're actually learning how to be flexible, how to lead, but how to adjust at the local level, particularly in the Comprehensive Primary Care Plus program. What is not in any evidence report, but all the payers that participated in the first iteration of CPCI, all the Medicare, all the commercial payers, were sufficiently convinced by the benefits of the multi-payer work that they all signed up for the next round. So if you want the strongest evidence, all the Blues plans, the for-profit, the local, the regional plans that had participated in the first 4 years of CPCI, a lot of acronyms here, have all signed up for CPC Plus as it's expanded. That's the biggest vote of confidence that we're on the right path here. So now we're going to hear from Michigan. I really want to thank Ann and her team for putting this report together. I want to thank the folks at the Graham Center for really putting some rigor into this, Blue Cross and Blue Shield Association for sponsoring today, and also Representatives Courtney and Rouser for their insight and wisdom around forming a primary care caucus, because I think it's essential to the future. What you're going to hear in Michigan is how they're making it work in a specific place, how they're taking the direction set forth by Medicare. They're adding large commercial payers who are rooted in the community, who really care about this. They're forming local partnerships. The doctors here said that I had to sit between the payer and the provider because, you know, that's usually that they're at cross purposes. Not so in Michigan. You can actually get collaboration working on these sorts of issues, and you can get something that works for patients, and we're going to hear from them as well. So I hope these policy ideas are helpful. Now you can hear the difference that it's making locally. Thanks.
So as Jean is making her way to the podium, let me introduce her briefly. Jean Malouin Dr. Jean Malouin is the medical director for Blue Cross Blue Shield of Michigan Value Partnerships since 2012, and she's responsible for the patient-centered medical home, organized systems of care, and other Blue Cross Blue Shield of Michigan initiatives. She's on the family medicine faculty at University of Michigan, and I know from prior conversations with her, she still practices one day a week and has only recently really moved much more into plan administration. So she has a lot of recent experience as a physician and now as a plan executive.
Thank you.
You need the poster.
Yes, I do need to lower this now. Thank you. And could you help me pull up my slides? Not sure where they are. Well, so while she's doing that, thank you. Good afternoon, everyone. It's really, truly an honor to be here, and thank you for spending a few hours of your day with us. I also would like to thank the PCPCC for inviting us here and for their long-standing support over the years. I'm very grateful for that. Also, the Blue Cross Blue Shield Association and the Milbank Fund, who has been an incredible supporter of primary care and all of this work. So that has just been wonderful. So I'm going to tell you a little bit about what's going on in Michigan here. So the Michigan PCMH landscape is a little bit different than some of the other states in that most of the PCMH practices in Michigan are actually designated or recognized through the Blue Cross Blue Shield program. This is the largest regional program in the country, and it's composed of 12 initiatives that were designed in collaboration with the provider community, and Dr. Stefanik was part of that, I believe, originally. the emphasis is really on all-payer population-level transformation. We began the program in 2009. It's been growing ever since, and we now have 1,709 PCMH practices recognized as of this year, with almost 4,700 primary care providers. We're really pleased that it is recognized by CMS for full MACRA credit, along with 4 of the national programs, and it has served as the foundation for several multi-payer programs. And the program is kind of unique in that there's no payment that is required by a practice in order to seek designation. And Blue Cross actually pays for both capability building, so building the stepping stones to being a patient-centered medical home, but also pays for recognition once the practice has achieved designation. I'm not going to go through all these in detail, but these are some of the characteristics of over 99% of the PCMH practices that are recognized in Michigan. And these practices, these capabilities are validated through Blue Cross has a field team that goes out and visits these practices. Having been on the receiving end of this, it's a bit of an intimidation to have someone from Blue Cross come out back in my old days as medical director, but to help educate the practices and as well as ensure that these capabilities are all in place. And I think the first one is one of the most important ones, having 24/7 access to a clinical decision maker when patients really just want to know if they need to go to the emergency room or if it can wait until the next business day. So these are some of the results that we saw in 2016 compared to non-patient-centered medical homes in Michigan. And you can see there's significant decreases in utilization, emergency department visits, radiology usage, and inpatient discharges. And this is in the adult population. And then in the pediatric population, we see lower rates of emergency department visits, and including primary care sensitive emergency department visits. And these are visits where someone could have, this could have been taken care of in the primary care office if they had had an opportunity to do that. So also, you heard some mixed results on quality outcomes. We have seen some significant improvement in preventive services in the PCMH practices in 2016, which 28% higher incidence of well child visits, 21% higher incidence of colorectal cancer screening as examples. So these are just a couple of studies that were published in 2015 showing some of the results of the Blue Cross Patient-Centered Medical Home Program. And these are looking at breast, cervical, colorectal cancer screening rates compared to non-patient-centered medical homes and significant improvements in the PCMHs, and also looking at positive associations with the amount of PCMH implementation and quality of care and use of preventive services. And here's a study that was out published in April of this year. Probably didn't make it into your study here, but this just showed in conditions that were being managed in the patient-centered medical home, there were significantly lower rates of ED utilization and hospital admissions. So, as Chris mentioned, CMMI has just been a wonderful supporter of these multi-payer initiatives. And so Michigan has been the happy recipient of being in the MAPCP project from 2012 to 2016. It was the evaluation only encompassed 3 years, but the program was actually funded for 5 years. We are also in the state innovation model, PCMH pillar, and also in CPC Plus, which was mentioned earlier. So this is the Michigan Primary Care Transformation, which was our MAPCP equivalent. We had 350 practices throughout the state of Michigan, 37 physician organizations, and much of our work is actually done through physician organizations. We work with physician organizations who in turn work with their practices. So we had almost 2,000 PCPs covering 1.2 million patients, which is about 12% of the population of Michigan. And our primary intervention was actually care management, and we had a standardized training program that we developed, and through this, as well as the SIM and the CPC Plus, we've trained about 1,000 care managers using an evidence-based program. So, and you can see the multi-payer nature of this. Having been in one of these practices myself, that's where my practice is, we could not have done this work without support from all these payers, both federal, state, and commercial. So results to date, this is the result that YALDA did not have available, actually when the report, the PCPCC report was published, but you can see that Michigan actually had the highest return on investment, even though it was the largest of the 8 programs, 4.54, with a net savings of almost $230 million across the first 3 years of the project. Blue Cross also conducted an internal evaluation during years 3 and 4 of this project, and this really just looked at patients that had the intervention. So this was patients that, in the Blue Cross population, that actually received care management services compared to a comparable risk-adjusted group that did not receive the services, that were in patient-centered medical homes that were not in this project. And you can see that the treatment group had $144 lower PMPM medical costs, 37.9 fewer ED visits, and 40 fewer inpatient admissions per 1,000 members. And we're pretty proud of this result. I think it shows a lot of, it tells a lot about the work of the physician organizations and the physicians in Michigan, and also the fact that this program has been in place since 2009, so it does take a lot of time for this to work. So some of you may have seen the final MAPCP report, but the 2 states that had a positive ROI was the Republic of Vermont as well as Michigan. And there were mixed results in the other states that were participating. And this was, we did a survey of adult patient experience during the demonstration project, and you can see that this graph couldn't have looked nicer if I had just made it up, but I didn't make it up. So the purple are the MyPICT practices, and then the green is a patient-centered medical home control group, and the yellow is a non-patient-centered medical home control group. And you can see that patient satisfaction was statistically significantly higher in domains of access, communication, coordination, self-management support, and comprehensiveness, along with provider rating. So I'll finish off with, so what have I learned? And I was actually the medical director of the Michigan Primary Care Transformation Project in my role at the University of Michigan. So I've now moved to Blue Cross full-time, although I do maintain a small practice 1 day a week. But things I've learned, strong visionary physician leadership is really essential for this work to occur, and we really, at Blue Cross, have really worked with the provider community and the physicians in the provider community to really strengthen their understanding of this work, because they're the ones that, if they don't believe that this team-based care is going to work, then it won't happen in the practice. We've also learned that the role of the convener is very important for large-scale change, and in Michigan, the physician organizations have served as the convener, and I think it's very difficult to do large-scale transformation when you're trying to do it one practice at a time, and I think, CPC Plus, that's what CMMI is trying to do, and it's very difficult, and we've been working with them, and they've been very collaborative in understanding the role of the physician organization in that we kind of teach them to teach their practices. So I think that's really important, as probably everyone in this room is not thinking about small demos, but they're thinking about how to make large-scale change. Some of the factors I think are critical to the development of team-based care, as I won't belabor this, but multi-payer support is really critical. Ongoing care team education and support. This is kind of like having a new baby in the family when you bring a care manager into a practice, and it's not something that instinctively happens. Maybe Dr. Stefanik is going to talk a little bit about this, but it does take a lot of time to figure out how those new relationships work. So it's very important to provide ongoing education for team members, and we've continued to do that through our Care Management Resource Center at Blue Cross. And I think we need to move from the concept of transformation to the expectation that this is business as usual, because whenever people talk about transformation, there's always the temptation to the understanding that you can go back to how you were. And I think it's scary to think about transformation, but if we expect team-based care and the attributes of the patient-centered medical home to be as common as the person who checks you in and checks you out in the clinic and as expected, and I think as Yalda mentioned, teaching our residents, teaching our medical students these models will be the way that we help perpetuate that. And the physicians who don't believe in this, eventually they're going to retire and they'll be replaced by people who this is all they ever knew. So I think that's really important. But in order to do that, we really need sustainable funding sources. And that's something that CMS has been incredibly grateful with, generous with this support 5 years at a time instead of 3 years, as they had previously done. But we need something that's going to go beyond the 5 years. So that's my plea here. And all of this really takes time, so I don't have to echo that again. But so, thank you for your time.
Thank you very much.
And with that, I'm going to introduce the real star of the show, Dr. Greg Stefanik. Dr. Stefanik has been a practicing family physician in Alma, Michigan since 1991. He's employed by Covenant Healthcare, headquartered in Saginaw, Michigan. He led his practice, Gratiot Family Practice, along its way to becoming a patient-centered medical home. Dr. Stefanik strongly believes in an empowered, proactive patient backed by systems supporting them in their efforts. Besides serving his patients, he also serves as the medical director of the Gratiot County Medical Physician Organization and is president of the Great Lakes Organized System of Care. Dr. Stefanik earned his degree as a doctor of osteopathic medicine from Michigan State University, go Green. He also holds a Bachelor of Business Administration in Accounting from the University of Notre Dame. And he's been a wonderful, wonderful partner to Blue Cross. He's not here by accident. He's here because we can always count on him. So please welcome Dr. Stefanik.
So this is hard work, what we're talking about, changing healthcare. The one advantage we have, though, is that we are all patients also. And so we all know what it's like to be a patient and what we should expect by being a patient. So what I'm going to talk about today, mainly two things, is number one, is how does this feel from a provider standpoint of this transformation in patient-centered medical home, and also what does it feel like to be a patient in this model? And I think you'll find it interesting from that perspective. We have a motto in our office is that patients won't care how much you know until they know how much you care. And so I think it's one of the secret ingredients to this whole process is just that element of caring. My background, just a little bit to let you know, and yes, thank you for Blue Cross for inviting me here. And disclaimer, they are paying me for my time to be here, but I'm taking 2 vacation days, which they're not reimbursing me for. And I am passionate about what we're doing here in Michigan. And so although Blue Cross does call on me to speak on some occasion, they don't tell me what to say, and there are times I disagree with them also. But we have a great working relationship, and I think that's a credit to both of us. I am not a burned out physician. You hear talk about burnout these days. All physicians are burned out. Oh, they got so much load. We got paperwork. We got mounds of stuff. Yeah, we have that stuff. But we also have the incredible opportunity to help people every single day. And, burnout's defined as that you're fatigued, that you're cynical, that you come home at night, you just can't think of doing anything else, and that you're ineffectual at work and you have no purpose, okay? I've never been more energized in the work I'm doing right now. Back in the old days when I started, back in 1991, I was truly Marcus Welby. I delivered babies. I took care of my patients in the ICU in the hospital. I first assisted on surgeries. I came to Mike to do C-sections and assist on C-sections. I went to nursing homes. I don't do any of that anymore. It's been 20 years. I delivered babies for 20 years, and it has been 5 since I haven't. I miss it, except not the late nights. But I am more busy now than I've ever been in my office because the systems that it takes to take care of people when they're healthy and keep them healthy are totally different than the systems it takes to take care of sick people. And one could argue, we spend too much time trying to rescue people at the brink of death and illness instead of focusing our time and energies on keeping the healthy. And I think that's got to be one of the things that pervades our healthcare system as we go forward. We can't forget the healthy people, too, because that's the ones that eventually go down to the chronic illness road. And I think there's a real advantage, and the emphasis has to be on that at some point. Yes, we can measure the immediate difference in taking care of a sick person and making them a little less sick. But what about if they never get sick to begin with? That's really the value is in the long run. I want to show you a quick clip of what my patients feel like is to be in a medical home, and if I can find it on here. If I close out of that one, and that one, and that one. It's got to be down there somewhere. A little background on this clip. This was done by my organization to talk about what patient-centered medical home is, and so I've had a couple patients that agreed to be interviewed, and I want you to just get a sense of what they have to say.
How are you feeling?
I feel
much better than when I sent the email this afternoon.
No. That's not good. So I don't know what happened there, but we thought we had it working. In the video, these patients talk about what it's like to be in a medical home. And again, I'll see if she can get it downloaded again or not, but that's okay. I'll show it if we have to. But I don't really care if my patients can tell me what a PCMH is, but I certainly want them to tell me what it feels like to be in a PCMH practice and how they feel cared for. I'll give you an example of something happened this weekend. I was on call this weekend. I got a call Saturday morning at 10 o'clock. Okay, let's try it again here. So how are you feeling?
I feel much better than when I sent the email this afternoon.
Okay, that's good.
That's right. Diane contacted her doctor after hours, and her doctor not only answered her concerns, but shared his cell phone if she had any emergency questions.
It makes me very comfortable to know that I have that backup. Yes, I know I can ask him anything at any time, and he'll have an answer for me. It might not be the answer I'm looking for, but he'll have an answer for me.
Covenant doctors take that communication seriously, and so do their patients.
One of the nicest things I like is that Dr. Stefanik lets me call him on the cell phone. Now, I try not to abuse that. Because if I did, I'd be calling him sometimes at 3 o'clock in the morning.
She has.
Seems to be, as you get older, I don't know, a nice prime time for things to act up.
Many of these questions stem from books that she reads about her condition.
Some of it I understand, and some of it is way beyond, and I don't want to know about it, I don't think. And I do like to read a lot about nutrition.
Nowadays still, if a patient comes in with stuff they learned off the internet, sometimes you get that roll of the eyes from doctors and say, oh gosh, here we go again, more internet stuff. And I think, why? We want patients to be in charge of their health. And so they're bringing stuff in, they're reading about their health, they're learning about their health. That's what I want them to do. And sometimes information's not so good, sometimes it's very good. And it opens up dialogue and discussion. So I think that's important that they have that permission and understanding that, hey, I'm in charge of my health and they're here to help me.
Dr. Stefanik is already seeing the improvements from this improved communication.
I can't tell you how many patients in the last year or 2 years I'm seeing remarkably differences in how they're taking care of themselves. And they get it. They really do. It's one of those things that when you tell them, they kind of just shake their head, yeah, man, I get it.
I'm in charge of my health. And he's my backup. He's the health professional. He's the one that did all the schooling, and he has the final say. But I think that every person should be in charge of their own health.
I am so different in my exam room now than I used to be with my patients 3 years ago. And I do have this discussion with patients that it's not my job to take care of you. It's your job to take care of you, and my job to support you.
I've become kind of a buddy of Dr. Stefanik. I think that's what we call it, a buddy relationship. And I can tell him how I feel and a little bit about my life. And that helps him understand, too, maybe how I click.
So I would say those patients feel cared for. And it's no magic thing except I allow them to tell me what's going on. I allow them to read things. I allow them to ask me questions. I allow them to come in and say, I have this need or concern, and I will answer that concern for them. Again, I don't care if they know what a PCMH is or can define it, but I want them to know how it feels. If you notice several principles in the PCMH in that video, access after hours. They are available to get a hold of me. I rarely get called on my cell phone, even though all my patients have my cell phone number. They like the backup. They like to have that. They feel comfortable with me. They feel comfortable because I give them time. And everybody, one of the basic human needs is to be understood. And I feel like I give them the chance to let me understand them. They read about their condition. They go on to research. My visits are better when patients come prepared after they've read about their own condition. They have permission to take care of themselves. Back when I was in medical school, and we're going back to the 3 and 5 rule here now that Chris started, there were 3 rules about being a good doctor. Number 1, you had to be available. Number 2, you had to be affable. And number 3, you had to have good ability. And the importance was in that order. If you're the best doctor with a great ability, but you can't communicate or they can't get a hold of you, then what good is it? I have added 2 A's since then. This is an original thought. I don't have many original thoughts, but this was an original thought. Number 4 is we allow them to take care of themselves. We give them permission. How many times in the past have we not let patients take control of their own health? We say, well, you just do what I tell you, or just take the green pill or the blue pill. That's not allowed anymore. They have to come in with their medication list. They have to know what's going on. They have to question whether tests are appropriate or not. They email me all the time and say, what about this? Do I need this test? Do I need this test? We allow them to take care of themselves. And the 5th A is we assist them as they try to take care of themselves. And that's different model than us trying to take care of them. And I'm telling you, in the PCMH model, it doesn't work to force things down from the top. Now, ironically, PCMH stands for patient-centered medical home. Probably the area we still need to improve the most is making it more patient-centered. We still don't give patients enough input. We don't give them enough input into the process. We don't know what they're feeling or thinking enough, and that's still something we're working on. But I'm telling you, when you do that in your practice, it's one of the biggest avoiders or biggest energizing things in your practice. Biggest avoiders of burnout and the most energizing thing in your practice is you give these, when you have this interaction, and it's not my responsibility anymore to make sure they're healthy. It's my job to support and guide them, and it's actually really fun. One of the big advantages is now with patient-centered medical home is our staff and how our staff works together. I have, you've heard a term called scribes. Scribes are people who come in the room with you and actually do the transcribing of the electronic record, so I don't have to go back to my desk and spend another 10, 15 minutes just typing everything I just said to the patient. But they're much more than scribes. They're an integral part of my team. Now, my nurse Amy, who is now with me in her 24th year with me, last year she went off probation and trial basis. She's now officially okay for now. But I told her that's still, I can take that back anytime I want. But she is now in the room with me when she does this. And at first, honestly, she didn't like it very much. But she is learning so much, and she does so much of the work that I used to do myself. She already has her immunizations lined up. She already has their wellness screenings. Do they need a colonoscopy? Do they need a mammogram? Do they need a pap smear? That stuff's all done before I even get in the room. And I'm in the room, they'll add saying, well, you know what? She hasn't had her cholesterol checked in 6 months, or she needs an A1C level done. Or, you know what? She wanted to ask you about this, and I want to make sure that she gets to this. They help guide the visit. So I have 2 nurses that I work with, and we're not just, they don't just room the patient anymore. We're an integral part together. We have a shared purpose and culture, and that is to really do the best job we can for our patients. We pride ourselves on taking care of our patients' needs, and the PCMH model helps us, provides that structured environment for this to happen. Not everybody uses scribes, and at this point, I don't understand why. I mean, I think it's one of the secrets to primary care as going forward is everybody has a scribe. But again, they're not just scribes, they're integral team care assistants, and it's just remarkable how it's really energized my practice. Probably one of the big things also that you need to have a reasonable employer that understands that just volume of patients isn't the way to go. Now, because of PCMH and because of the value-based models we have in Michigan now, a large proportion of our income now comes from these value-based programs, which gives us opportunity to hire care managers, to hire scribes, to do these things that we couldn't afford before. So it all works together in this whole model, and it's slow, it's evolving, but it's working together, and we're slowly totally changing the way we deliver healthcare in our practice. And again, it's exciting. And I think I already mentioned, you saw it, I am demanding that my patients take better care of themselves. We're increasing that patient engagement. We're increasing their activation. There are some patients who barely can keep a list of their medications. But there are some patients who can understand the pathophysiology of their disease. Every patient is capable of knowing more about themselves, and it totally protects them. A lot of doctors complain, well, I'll get sued if I don't order this test. Talk to the patient about the test. They may not want it after you explain the risks and side effects. I don't have that problem with patients demanding tests to me and me saying no, and they stomp out of the room because they didn't get what they wanted. When you have a conversation, you explain to them, they kind of realize, well, I guess I didn't realize that could cause me side effects. I don't want those side effects. So we have this discussion with patients now, and it's a lot of fun. Again, most physicians, when they went to medical school, did it because they wanted to help people. They didn't do it because they wanted to make lots of money at the patient's expense. They didn't want to do it because they wanted to get out of there at 5 o'clock at night with no extra work to do. They did it because they cared about people. They're empathetic. They really want to help people. Sometimes, though, along the way, the processes and the incentives does kind of beat them down a little bit. The electronic medical records, it's a love-hate relationship. Every doctor hates it. Every doctor can't imagine practicing without it. But it really has done a whole lot of things to advance our ability to take care of patients in a typical fashion. So there's lots of things I could talk about, and they're almost out of time. I'll just share one story that happened this week and maybe give an example, too, what a PCMH is like. So Jim calls me at 10 o'clock on Saturday morning. He says, Doc, I had a cystoscopy, which is a bladder procedure that he had 2 weeks previous. He got a urinary tract infection after the procedure. They gave him an antibiotic. He called me up. I called his doctor on Tuesday. He said, Doc, I'm still having symptoms, burning and frequency. If any of you ever had a urinary tract infection, they're awful, okay? I mean, just absolutely awful to suffer days with them. So he calls on Wednesday for the result because he got a urine specimen on Tuesday. No, it's not back yet. It takes 48 hours. Okay, he calls back on Thursday. Nope, it's still not back yet. This is the specialty office. Friday afternoon, he calls him again, and she says, I'm sorry, it's still not back yet. You'll have to wait till Monday. Can you imagine being told that you know, she had to sit there? So he calls me on Saturday morning. I said, first of all, Jim, why didn't you call me last night? So I look, I get on the computer, see the result. It's right there. The antibiotic, I changed the antibiotic, I sent it to the pharmacy. It took maybe 5 minutes to do it. I saved him a hospitalization. I saved him pain and worry. But the ironic thing is he had the capability, if he had signed up for our patient portal, to go look on himself to see the results. He could have, when he called Friday, he could have told the hey, I've got my results right in front of me. This is what it says. I don't know what it means, but this is what it says. He could have, you know, already had results. And he also could have said, when you do that urine test, send a copy to my primary doc, Dr. Stefanik, because we wouldn't have left that Friday with those results in our inbox, knowing he was having that problem. So that's what a PCMH is giving the patients the care they need at the time they need it. It's not being told, I'm sorry, you'll have to wait till Monday to get the results. The nurse could have called the lab and got the results for him that Friday. I don't know why she didn't do that. But that's kind of what a PCMH is like. That's what it's like to be a practicing physician. It's an exciting time in medicine because we really have a chance to make a difference, I think, in people's lives. I love the work we're doing in Michigan. I guess I don't realize how special it is until I hear about other states are struggling. I think a large part is because of the camaraderie we have between the health insurance and the physicians themselves. We really are working together to try to do something better. It's not easy. It's hard to change physicians' patterns. But you know what? The specialists are on board with this too. It's not like the specialists are saying, I don't want to do it because it's not good for the patient. They can't argue that it's bad for the patient. All they can argue that it's different than we used to do it. Or it might mean I have to change my systems a little bit. Or it might mean I'm not quite as high prominent as I used to be. But they can't argue that it's not better for the patient. So specialists, they're not kicking, dragging, screaming down this process. They're kind of like, oh, I knew this was going to happen. But they can't really argue about it because it's really better patient care. Physicians are motivated by better patient care. We're motivated by competition. Okay? We're motivated about doing that right thing for that patient. We're motivated by reducing our pain with paperwork and forms and signatures and those kind of things. Yeah, we're motivated by money too. But believe it or not, that's not the thing. And it's been shown over and over again. That's not the thing that motivates physicians the most, is money. It's how do we make this process more streamlined and easier to handle. So with that, I will close it. I appreciate all you coming today and suffering through the sweltering heat. I see where the budget cuts started. But we're here to answer questions. So please ask questions.
Thank you so much to all of our panelists. Now we're going to open it up for some questions. But before we do, I noticed that there were two themes, actually, that were very dominant across all of our speakers today. One was, we didn't want to wait until Monday. And all of these changes are happening now in real time, and they're building, and we can see that they're accomplishing a lot. There are many results. But to get to the big kahuna results, where there's going to be tremendous cost savings and improvements in quality that are not mixed, but absolute improvements in quality, is going to take some time. And so, here in Washington and in state houses across the country, I think we look for that silver bullet, that overnight success. One shot, it all is transformed. But this is a process where we are seeing each day some successes, and over time, huge success. So let's roll this out across the entire country, and we need your support to do that. Now, we've got some time for questions for any of our speakers. Please, don't be shy. In the back.
Hi there. I'm in the PCPCC. I just had a quick question. My eyes aren't so good anymore. So on your slide, did the Michigan State employees get involved in the PCMH? Are they, the state employee benefit plan? Were they part of it?
There's self-funded customer, I think, with Blue Cross. Is that what you?
Yeah, right. The state employees, because I know that at different states, the high cost for financing the employee health, the state employees is becoming a big issue. I'm just wondering.
Yeah, I think they were part of it.
They were part of that.
Yes. And if you can identify yourself, that'd be great.
Sure. I'm Soraya. I'm from Judy Rossman's office. It's in Maryland District. I'm just curious, based
who have their own way of doing things. If a patient asks questions, it interrupts their flow. Or there are some physicians who feel like, well, if they know about their own health condition, they won't need me anymore. Or like the woman who texted me, sent an email yesterday who said, I think I should have my thyroid checked before my atrial fibrillation ablation. You know, some docs would take offense to that.
Yeah.
But atrial fibrillation can is caused by thyroid problems. It was a perfectly appropriate question. She had just had her thyroid checked 2 months previous, so I kind of go back and said, great question. Thanks for asking that. You're exactly right, but I think it's not your thyroid, but I still want to do what we can. But there are docs who are threatened by that for some reason. And mostly it's just because it's always the way we used to practice. You know, and it's just a different kind of mentality. But it's slowly changing, and we have docs on board, especially when you tell them that if you become qualified for PCMH, you get 5-10% more on every single procedure you do. You know, so the docs listen to that to a certain degree, but they also listen to other docs that listen to docs like you who come to them and say, hey, this is what's happening, and this is why we think you should get on board with this and why we should do it. It's hard to change patterns because we're kind of stubborn. And they say like trying to get physicians to do something is like herding drunken cats. It's not always that easy because we're kind of stubborn and I think we know it all sometimes. But it's slowly changing. I think it's good. And if you are a patient in a practice where you feel like your input's not valued, you should go somewhere else.
Chris.
I'm going to do a shout out to the large payers like Medicare or Blue Cross in Michigan because not so much for Blue Cross, but for Medicare, but the dialogue between primary care docs and payers has historically been as follows. The primary care doc says, I'm doing the work of the Lord, give me the money. And the payer says, show me the results, and I'll give you the money. And they're just kind of the loggerhead. Show me that you've reduced ER, and then I'll pay you for reducing because you saved me some money. And the doc says, give me some money to reduce my emergency room, and I'll save you money. And the development over time of these standards for patient-centered medical home, and transparency is part of it. But they go to Blue Cross and go to Dr. Stefanik and say, can you take call 24 hours a day? Do you have registries for your sickest patients, your people with diabetes, your people with asthma? Do you have an electronic health record? And the change has been that if he says, yeah, I have that stuff, they're putting money up front. They're saying, you know what, we know as a result of this evidence that these are the sorts of things that are going to save us money. So we will invest up front as opposed to simply wait for him to show that he's reduced the ER. That's a real change. And what Blue Cross has figured out and Medicare has figured out is it's not all that much. The little bit that they pay him to put this stuff in place is a pittance compared to the extra CTs that get ordered at the emergency room because the scan wasn't available, because the patient landed at the emergency room in the first place. So having some standards for what constitutes high-quality primary care and having payers that are willing to pay based on them rather than just wait for results, really, and have it be consistent, have Medicare and Blue Cross get together and send really consistent signals. That's what's different.
And if I may add just one more thing to that, interestingly, where the money comes to fund a lot of Blue Cross programs is actually from the doctor right at the top. So 5% of every claim we submit goes off into this fund. So right away, we lose 5% at the top. But I also, now I think my practice is 25% more in every outcome physical because of the system we have in place now. So it's a net 20% gain. So we're using the carrot, but we're also using the stick with it too. And he's actually realizing that it's not business as usual anymore.
Thank you. Great question. Yes.
Hey, I'm Liam I'm an intern in Representative Castor's office. I was wondering what you guys think that representatives could do on, a local and a national scale to help implement these types of changes and these types of new policies into their communities and such to improve healthcare.
I knew someone would ask that question.
Chris, would you like to start?
Or I can
Or
jump in
yes,
too,
Justine.
and it's a great question. I think making sure that there's a continued investment in primary care. I think MACRA took some good steps to move away from fee-for-service, so rather than just paying for volume and quantity, to really moving in a direction of paying for outcomes and moving into alternative payment models. I think as that continues to be implemented, as you heard the themes today, ensuring that there's flexibility at the local level, but also alignment. You don't want the government to start over or have different standards or measures. If there's something that's working, Michigan's a great example in the community. Build on that success and make sure, as I mentioned earlier, that physicians are rewarded not only for their fee-for-service in Medicare as MACRA gets implemented, but open it up to Medicare Advantage as well, which is already doing many of these things because you have private plans behind it. And continuing to make sure that there's continued investment into information technology, data sharing. I know the health plans are working tremendously to share data outcomes in these reports, but making sure that there's continued investments in building out the technology and the database and the tools would be extremely helpful. So just a few things. I don't know, Chris or others, if you have anything to add.
As I talked about, Justine went through the list. Well, Medicare's work around payment reforms is really important. I ran a Medicaid health plan. The first question we would ask when we were contracting with docs is, what's Medicare do? How much does Medicare pay? And then we go up or down off of that. And the fact that Medicare is out there doing alternative payment arrangements, talking about how to align payers, sending these signals through CMMI, it's just immensely important locally. And then if any of you are political scientists, this is a federalism question. This is what do we standardize at the national level, and how do we customize at the local level, and how much variation can we handle, because the dynamic in Michigan is different from the dynamic in Texas or other places. And we learn how to do that. It doesn't happen as quickly as anyone would like, but this is a considerably more sophisticated, more informed evidence report than 6 years ago when PCPCC did the first one.
Right.
We're learning this.
That's right, 1,800 journal articles to choose from and get the creme de la creme. I think also for those of you who maybe haven't been watching this movement for a while, I just want to point out that it began really under a Republican administration, this whole drive towards value-based payment and care delivery reform. So this is something that has had this deep bipartisan support and has really evolved over time. And I think the other thing that we've seen is so much public and private collaboration. And if there's anything that I think both sides of the aisle agree on is that, if the public and the private sector go in different directions, we're not going to make progress. We have to really come together and have an agreed upon approach to how we incent and how we change payment, or else it's very disruptive for those who are providing care. And so we really want to have a common approach, common set of signals. And I think, we're making progress. We're on that path, and we just all want it to go forward.
I said in docs aren't motivated by money, number one, but when a medical student has $300,000 in debt, and they get paid 4 times the amount they get cardiologist versus a primary care doc, where they eventually go to. So what can we do to incentivize primary care docs? We charge them less for medical school. Can we do loan forgiveness if they choose primary care? What can we do with that? That example I gave of the man who called me Saturday morning, I got to pay 0 for that phone call. How much money did I save the system? Did he go to the ER? He didn't have surgery? So how can you incentivize those kind of things? The calls, the after hours, things that the primary care doctors do. So what can we do to incentivize primary care? I think we need to still work, because we know it. We know it works. We know it's the secret to a functioning, thriving healthcare system. But what have we done substantially in the last 5 years to really encourage? And the numbers aren't there. We're not seeing more primary care docs coming out of medical school. So until we do that, other countries have 50-50 splits between specialists and primary cares, and we're like 20-80 or something like that. I mean, it's awful. And again, why? Because the specialists seem to have more prestige and make more money, and there's something wrong there.
And I just wanted to I don't have anything new to add, but I wanted to really reiterate what Chris said about CMMI. CMS has just been a wonderful partner, and it's been much different than I thought it would be to work with CMS, I guess I'll say. And that it's really, really important that CMMI work continues in order for this work to continue.
No hiring freezes.
Yeah. There's a question in the back.
Yeah, I'm Zach Levin from the Grant Center, and I have a question that's maybe targeted a little bit to Dr. Malik, which is that since Michigan, did an all-payer, as far as getting practices to kind of uptake the patient-centered medical home model, how much did the practices payer mix kind of dictate their uptake into the program?
I think it has mostly
that the practice is going to transform. You still need the conveners, you need the practice transformation assistance. But that's, you don't have to get every payer. You got to get about 50 to 60% of the population.
Yeah, and you know, one of the things about Michigan is that some states have a mandate for payers to join these kind of multi-payer initiatives, and we did not. So we went around when the MAPCP, you know, we were essentially trying to turn a single payer initiative into multi-payer, and did a lot of begging and pleading with the Medicaid managed care plans and the other commercial payers. But I think, you know, having a state mandate actually helps with that considerably.
And if you want the inside baseball, it's the self-insured population. They are the last to the table.
I can vouch for that.
These big employers, you know, you get Medicare billing up, Medicaid, the commercial payers, self-insured are the ones who say they're most likely to freeload. And they point to their risk of preemption, and it's just not fair.
Well, we are at our time. Let me, join me please in thanking everyone, and please have some snacks. And I think our speakers will be around for a little bit if you have further questions.